Good evening, everyone, and welcome to tonight's Fellows Corner. We have Dr. Ahmed, who will be presenting tonight, and we have Dr. Bawaadam, who sits on the SAB's Education and Program Committee, will be moderating this session. I encourage and influence everyone to ask their questions throughout the presentation. There is a question feature that's located on your control panel. You can press the drop-down arrow and submit them there. Dr. Bawaadam will go over the questions at the end of the presentation. At this time, I'll hand it off to him so he can get us started with Dr. Ahmed's presentation. Thank you for joining.
Thank you, Emily, for that wonderful introduction. And I'm excited. I'm excited to be once again moderating this session, nonetheless, for my second year and Chief Pulmonary Fellow of Rosalind Franklin University, Dr. Ahmed. So let me introduce you to Ahmed, who's a second year Pulmonary Fellow at Rosalind Franklin University of Medicine and Science and Captain James Lowell Federal Healthcare Center, North Chicago, VA, better known as. And he has made several strides in the last 2 years, several contributions to multiple publications, ATS, CHEST, and currently wrote 2 book chapters that he just lead authored and submitted just 2 days ago. And the most notable thing about Ahmed that stood out to me was his initiation or his involvement as a founding member of the First Responders Initiative of Pakistan, where he comes from. It's an NGO, it's a non-governmental organization that teaches emergency first response free of charge to all medical and non-medical professionals in his home country. It's a very noble deed, so kudos to you, Ahmed. So Ahmed values medical education, great patient-centered care, and here he's presenting a very unique case that also got accepted at one of the presentation meetings. So Ahmed, hand it over back to you.
All right, Dr. Bawaadam, thank you so much for the introduction. So my case is spontaneous pneumothorax exposes lymphangioleiomyomatosis, LAM, in a case of gravid uterus. So LAM is a destructive tumor resulting from the proliferation of LAM smooth muscle cells, lung, kidney, and axial lymphatics. This disease is due to either spontaneous or inherited via mutations of the tuberous sclerosis genes, TSC1 or TSC2, and it primarily affects young women. We present a unique case where pregnancy revealed LAM due to a sudden pneumothorax. 33-year-old female of European descent with no significant past medical history developed sudden onset chest pain and shortness of breath during the first trimester of her second pregnancy. An emergent CT showed spontaneous left pneumothorax and mild bilateral cystic parenchymal changes. The patient underwent several chest tube placements with upsize exchanges and eventual discharge with a one-way with tube and drainage kit that resulted in complete resolution of the pneumothorax. She was recommended thoracic surgery evaluation for a video-assisted surgical wedge biopsy and mechanical fluorodesis with possibly avoiding chemical fluorodesis in case of future transplant need. She deferred any surgical follow-up or intervention due to her pregnancy. There was genetic testing done that was inconclusive for Marfan syndrome, Birt-Hogg-Dubé, and tuberous sclerosis. The family history was suspicious for breast, colon, and gynecologic malignancy, but the records were unavailable. PFT had hyperinflation on it. There was air trapping consistent with LAM. The serum vascular endothelial growth factor, or serum VEGF-D levels, was within normal range. There was an uneventful normal delivery, and then the patient was eventually evaluated by IP. She had an HRCT scan, which I'll show on the next slide. There was bilateral, scattered, mild, thin-walled, cystic lung parenchymal changes. These are marked out here in the CAT scan here. So you see these small, I don't know if you can see my pointer here, but all the cystic changes are sort of marked out here with the green arrows. You've got the axial section here and then the coronal here. You can see upper lobe, middle lobe, lower lobe on the right side, left upper lobe, and then there's some in the left lower lobe also, but it's more prominent in this axial scan over here. Then she underwent bronchoscopy with mobile cone beam CT guided transbronchial cryobiopsy. A 1.7 millimeter RB probe was used for this with carbon dioxide and cryogen gas, the carbon dioxide cryogen gas, and then biopsy samples were collected, 2 each from the right middle lobe and the right lower lobe. She tolerated the procedure well without post-procedural complications. You've got the path slides here. H&E staining shows thin-walled cysts surrounded by rare spindle-shaped cells. This is figure 1C over here. So you've got the H&E stains. These are the thin-walled cysts over here, and then kind of hard to appreciate, but there's rare like spindle-shaped cells around it also. Then you've got further immunohistochemical staining that showed focal positivity for abnormal smooth muscle like Lamb cell proliferation in the lung stroma, and an immune positive reaction to both SMA and HMB45. So this figure 1D over here shows the lighting up of the HMB45 here. So that's consistent with Lamb. And then the treatment eventually was started for this patient because this was diagnostic. IV sirolimus was initiated and the patient was referred for transplant evaluation. So I'll dive into like cystic lung diseases now. Like this is like the differential diagnosis one thinks of when you see a case of cystic lung disease. There's like neoplastic, genetic issues, lymphoproliferative disorders, infectious causes, ILD, smoking related, other causes, and then diffuse cystic lung disease mimics. Now, in the neoplastic section, you've got LAM itself, which can be sporadic or tuberous sclerosis. There's like PLCH, pulmonary Langerhans cell histiocytosis, and some metastatic neoplasms can also cause this. Genetic issues like Birt-Hogg-Dubé, Proteus syndrome, neurofibromatosis, EDS, LIP, follicular bronchiolitis, Sjogren's, pneumocystis can cause cystic changes, HP, DIP, PLCH again, that's also associated with smoking. And then in the mimics, you've got emphysema, alpha-1 antitrypsin deficiency, and bronchiectasis. These are some of the malignancies that can cause it. And there's like primary pulmonary neoplasms, sarcomas, and metastatic epithelial tumors also, and lymphomas as well. This is the table talking about cystic changes that one may see. This is according to the Fleshner Society. A cyst is anything that's thin-walled, less than 2 millimeters. It's spherical. It's like a spherical parenchymalucency interface with normal lung. Then you can have cavity, like gas-filled space with pulmonary consolidation, or mass or nodule. It can be thick-walled, more than 2 millimeters typically, and it can be irregularly shaped than cysts compared to cysts. Bullae are like spherical focal lucencies more than 1 centimeter in diameter, bounded by a thin wall, usually less than 1 millimeter. It's usually accompanied by emphysematous changes in the adjacent lung. And then blebs are cystic airspace. Cystic airspace is bounded by a thin wall adjacent to the visceral pleura, typically less than 1 centimeter in size. A pneumatocele is approximately round, thin-walled, air-filled space in the lung, and it's most frequently caused by infections or trauma or aspiration of hydrocarbon fluids. Those are transient. Then you've got the different cystic lung diseases like LAM, PLCH, Birt-Hogg-Dubé, LIP, and amyloid. LAM, LIP, and amyloid are the ones that can cause diffuse cystic changes. Then Birt-Hogg-Dubé and PLCH are different. Like PLCH has upper and middle lung involvement, and Birt-Hogg-Dubé has like basilar and peripheral subpleural involvement near the vessels. Sizes can vary. Like amyloid cysts can become like the largest. They can be majority are larger than 1 centimeter. Shape PLCH cysts can be bizarre. LAM cysts are more round and uniform, like we saw in the CAT scan earlier. Birt-Hogg-Dubé is the only one where pathologic tissue diagnosis does not help you. It has like interparenchymal and subpleural cysts abutting interlobular septa, and they lack any abnormal cell proliferation. LAM, on the other hand, you can have infiltration by HMB45, which is what we saw positive in our case, and then LAM cells with smooth muscle phenotype. PLCH has S100 and CD1A positive Langerhans cells with the Burbeck granules that you can see on the slides. Amyloid disease can have like amorphous protein deposits. These have that characteristic apple green birefringence, and then the light chains, they lack that apple green birefringence. Then other than that, PLCH has micro and macro nodules with or without cavitation. They can have thick-walled cysts also. LIP can have ground glass attenuation, central lobular nodules. Amyloid can also have multiple nodules, if you can see. LAM is associated with pleural effusions, and chylous effusions is quite, it's like a significant finding in these cases because the smooth muscles kind of block out the lymphatics, and then you can have those chylous effusions. LAM can be autosomal dominant or sporadic, and so and Birt-Hogg-Dubé also is autosomal dominant. The other three are not inheritable. These are the three genes. So the tuberous sclerosis is for LAM, PLCH is BRAF and MAP2K, and FLCN for Birt-Hogg-Dubé. There's no associated genes for LIP and amyloid, obviously. Prevalence of pneumothorax is highest in LAM, as you can see over here, but the average age at first pneumothorax is sort of the same in LAM, PLCH, and Birt-Hogg-Dubé, as I've marked out. The rate of recurrence of pneumothorax is high in all three of these, LAM, PLCH, and Birt-Hogg-Dubé. LAM is the only one that can be exacerbated by pregnancy, and smoking related is PLCH. And when it comes to gender, LAM can occur in females mostly, and then LIP and follicular bronchiolitis also happens more in women. Over here, you can see LAM, PLCH, and Birt-Hogg-Dubé are all associated with pneumothorax. Then they have their other characteristic things, like LAM can have angiomyolipomas, scalous effusions. And if there's like tuberous sclerosis associated, then you can have those cortical tubers and seizures and skin lesions. PLCH is associated with smoking, skin lesions with Birt-Hogg-Dubé also. LIP has this HIV association, and then amyloid is mostly like chronic conditions. Light chain disease is also like lymphoproliferative disorders, chronic conditions. Birt-Hogg-Dubé can have pneumothoraces as well as LAM, obviously, and then there can be a family history of pneumothoraces with Birt-Hogg-Dubé. And other than that, you can see here for the lab testing, you've got serum VEGF-D for LAM, then serum and urine studies for diabetes insipidus and PLCH, genetic testing for Birt-Hogg-Dubé, and then LIP and then FB has polyclonal dysproteinemia, so you can test for that. Then LAM, the diagnostic yield for bronchoscopy is almost like just over 50% for LAM, about 30 to 50% for PLCH, and it's not very diagnostic for Birt-Hogg-Dubé. You won't even consider like a surgical lung biopsy here. Low yield is there for LIP, amyloid, and light chain disease because of the scatter of the disease. Chances of actually catching where the lesion is low. Then there's genetic testing that you can do, which I think we've already talked about. Treatment-wise, there's a difference. So LAM, you can treat with sirolimus, and I'll delve into this a little later. PLCH, you wanna have the patient stop smoking. You can do immunosuppression and then cladribine. There's no treatment available for Birt-Hogg-Dubé. For LIP and FB, you can do corticosteroids. No treatments available for amyloid and light chain disease. Over here, so here they just describe the type of cysts that you have, and then LAM and Birt-Hogg-Dubé and PLCH. For LAM, you can move on to scan for angiomyolipomas, do screen for tuberous sclerosis, VEGF-D, and then you do a transbronchial biopsy or VATS biopsy. With Birt-Hogg-Dubé, skin biopsies are important, family history, and then FLC and genotyping. And then for PLCH, you can do biopsies also. Notice here that if a cyst pattern is not consistent with previous presentations, then you end up biopsying it over here because it could be other causalities in that case. This is basically a summary of the recommendations in the ATS guideline that was put out in, I think, 2016 or 2017. They address 4 questions here. So they address HRCT as a sole confirmatory feature for LAM diagnosis. So the first recommendation, so all these are like conditional recommendations. The first one is for patients who have cystic changes on HRCT of the chest that are characteristic of LAM, but have no additional confirmatory features of LAM, i.e. clinical, radiologic, or serologic. We suggest not using the HRCT features in isolation to make a clinical diagnosis of LAM. The second question is transbronchial lung biopsy for histopathological diagnosis of LAM. When a definitive diagnosis is required in patients who have parenchymal cysts on HRCT that are characteristic of LAM, but no additional confirmatory features of LAM, i.e. clinical, radiologic, or serologic, they suggest a diagnostic approach that includes transbronchial lung biopsy before a surgical lung biopsy. And then with pleurodesis after a sentinel pneumothorax to prevent recurrence, they suggest that LAM patients should be offered ipsilateral pleurodesis after their initial pneumothorax rather than waiting for a recurrent pneumothorax to happen. And then the fourth one is pleurodesis as a contraindication to future lung transplant. They suggest that previous unilateral or bilateral pleural procedures not to be considered a contraindication to lung transplantation in patients with LAM. This here is basically an algorithm, and For LAM cases, they're suggesting that you should follow an algorithmic approach to diagnose it. If you have a clinical suspicion of LAM, you do HRCT chest with features that are characteristic for LAM. If that's a no, then you just think of another diagnosis. If it's a yes, then you can do a detailed clinical examination, and then that can sort of confirm, and you confirm a diagnosis of tuberous sclerosis LAM if it meets criteria. If that's a no, you can do the blood work, serum VEGF testing, non-contrast CT or MRI of abdomen and pelvis, chylous fluid, node mass aspiration if applicable. And it goes further down, you can check VEGF levels if it's greater than 800, renal angiomyolipomas, lymphangioleiomyomas, positive cytology, then that confirms LAM also in this case. But if you don't get a result here, then you can move on to like the histopathological avenues. Like if you need a diagnosis, then you can do transbronchial lung biopsy with characteristic features of LAM. If that's a yes, and that can give you a confirmed diagnosis. If not, then you delve into surgical lung biopsies, and then eventually that can confirm your disease. You want to have like the least invasive approach. Then transbronchial lung biopsy, the gist of it is it's an okay diagnostic yield, less invasive procedure, and then there's less procedure related complications, and then it's cheaper. The VATS guided surgical lung biopsy has been considered the gold standard for obtaining histopathological confirmation of LAM, but there's data in case reports and case series supporting transbronchial lung biopsy as a less invasive approach. Transbronchial approach has complications, pneumothorax and bleeding. And then understanding of the utility of transbronchial lung biopsy in LAM was informed by a small case series with the ATS guidelines. There were limitations and biases that provided a low confidence in the estimated diagnostic yield. It was about 50%. And then there was a complication rate of about 2 to 14%. If you compare the transbronchial lung biopsy to the VATS guided surgical lung biopsy, there's like 1.5 to 4.5% mortality rate. And then there's 10 to 19% procedure related complication rate. There's a theoretical pneumothorax risk with transbronchial lung biopsy, and then that risk still needs to be determined. There's other modalities like EBUS-guided TBNA of lymph nodes, transbronchial lung cryobiopsy, and there's some data out there which I go into. So this study here, it talks about safety and efficacy of cryobiopsy for the diagnosis of LAM. This was evidence enough to say that, a transbronchial cryobiopsy is good. There's another study here, they diagnosed pulmonary Langerhans cell histiocytosis using cryobiopsy. And this one right here did the same approach, cryobiopsy, to diagnose amyloidosis as a cause for cystic lung disease. Then there's diagnostic usefulness of transbronchial lung cryobiopsy in mildly affected LAM cases also. Like over here, they're saying that transbronchial lung cryobiopsy is a useful tool for diagnosing early stage pulmonary LAM owing to its appropriate specimen size for detecting LAM cases and a few crush artifacts. And then on the contrary, you've got this one systematic review in a case that they talk about a cystic lung lesion that forms after transbronchial cryobiopsy. They performed a chest CT 9 months later, and it showed resolution of that lung cyst. So they're saying that's also something to think about, using cryobiopsy to diagnose cystic lung disease, but then that cryo probe itself can cause a cyst, which you can watch for. Treatment options for LAM, mTOR inhibitor, TSC1 and TSC2 are tumor suppressor genes that encode proteins hamartin and tuberin that regulate cell growth and proliferation. Tuberous sclerosis patients have a genetic mutation, therefore the tumors happen. And then sirolimus or everolimus is this mTOR inhibitor that formed the complex with this component here. It inhibits mTOR and sort of, it works in TSC and sporadic LAM cases, both of them. It'll reduce tumor size of AML and LAM and the lymphangioleiomyomas, and then it can stabilize or improve lung function also. It'll resolve chylous pleural effusions. It'll inhibit VEGF production also. Anti-estrogen therapy isn't really recommended. And then overall, they're saying like GnRH analogs, oophorectomy, and progesterone don't work, so they don't recommend that. MMP inhibitors like doxycycline were also investigated in the past, but they're not recommending it. And then statins is something that statins like simvastatin and atorvastatin, there's studies that are being done. Other options are IFN and VEGF and CDK2 inhibitors. So that's being explored. The VEGF indicates lymphatic involvement. There's other things like immunotherapy and autophagy inhibitors that can be used. These are some landmarks in the history of LAM, essentially. Important ones are like in 2015, sirolimus was approved in the US, and then in 2016 and 2017, ATS and JRS put out practice guidelines. This is from the 2016 guideline that talks about mTOR inhibitors. There's a very strong recommendation for patients with LAM with abnormal declining lung function. They recommend treatment with sirolimus rather than observation. And then for selected patients with LAM with problematic chylous effusions, they suggest treatment with sirolimus before the invasive management. The other strong recommendation is VEGF-D as a diagnostic test. For patients whose CT scan shows cystic abnormalities characteristic of LAM but have no confirmatory clinical or extrapulmonary radiologic features of LAM, they recommend VEGF-D testing before consideration of proceeding to diagnostic lung biopsy. Confirmatory features of LAM include tuberous sclerosis complex angiomyolipomas, chylous pleural effusions, or ascites and cystic lymphangioleiomyomas. The doxycycline and hormone therapy are not recommended. And then this is like the indication for sirolimus. I was able to find this on this LAM website. Abnormal lung function, FEV1 less than 70%, progressive lung function decline. The decline has to be like more than 90 ml per year, refractory FEV1 decline, and refractory chylous effusions, angiomyolipomas more than 4 centimeters, or other measures suggesting substantial disease burden. This is an article that sort of, they looked into the database of LAM patients that ended up getting transplants for lung. I wanted to point out that like they looked at what type of LAM patients were included were considered for transplant. So the diagnosis of LAM was confirmed by at least one of the following criteria. They either had a lung biopsy or biopsy of a lymph node or other mass, and surgical explant at time of transplant, or they had a HRCT evidence of LAM. Diagnosis of LAM by HRCT required the presence of typical cystic changes diffusely distributed throughout both lungs without relative sparing of bases, in agreement by 2 of 3 expert radiologists. To summarize, LAM is a destructive tumor resulting from the proliferation of LAM smooth muscle cells, spontaneous or autosomal dominant inheritance via mutations of the tuberous sclerosis genes, TSC1 or TSC2. There's a female predominance, and then there's an algorithmic approach to diagnosis, beginning with evaluation of radiologic, clinical, and then lab findings. Then you determine the need for transbronchial lung biopsy, and then the more invasive surgical biopsy. And then sirolimus mTOR inhibitor is indicated for LAM. That's all I have.
Thank you, Dr. Ahmed, for the excellent presentation. We'll bring Dr. Bawaadam back on now, and he can go over some questions with you before we end tonight's Fellows Corner.
All right.
Thank you, Ahmed. Thank you very much. It was a very comprehensive review, especially the path and the table that you showed about diffuse cystic lung disease, which are the thin wall cysts, the broad wall, PLCH, and LAM definitely falling along with nematoceles, amyloidosis, and the thin wall cystic disease. And we LAM generally sparing the apices, PLCH more the mid and the lower lungs on the juxtaphrenic angle. So this is important for fellows to know as to what constitutes thick wall, thin wall cyst, and what the etiology is and what the distribution is on a radiological criteria. I think it was very comprehensive. I wanted to ask you a question. Is there much difference between cryobiopsy from a surgical lung biopsy standpoint? I just want to know in diagnosis of LAM, which one would you prefer?
So this study here, they give some numbers to us. Like they're saying that so more patients with minimal cystic perfusion were diagnosed with LAM by transbronchial cryobiopsy, 26.3%, and then surgical lung biopsy was also 28.2%. That's not much difference. The p-value was just like the quoting p-value is less than 0.001, 0.004 over here. I know this is compared to the forceps biopsy, and this is like cryobiopsy, but the point is like the percentages are still quite similar between the surgical lung biopsy and cryobiopsy. You're getting a fair amount of tissue and you're getting diagnoses, so a cryobiopsy is the way to go.
Fantastic. And then the other question is how much reliability can you place on VEGF? Do you actually use VEGF to diagnose a patient with LAM, or is it used as one of the, as you mentioned, a test when you have high clinical and radiological suspicion, when you know biopsy has been done, can you actually proceed with just VEGF and high clinical suspicion?
You can actually diagnose with if a VEGF level is more than 800 picograms per ml, you can confirm a diagnosis of LAM. That saves the patient from the needle and a surgery, or a surgery further down. So ATS, JRS are saying that you can actually diagnose a patient. It's a strong recommendation to diagnose with VEGF.
That's good to know. That's good to know. Good to know. And it has a value assigned to it.
Of course, yeah.
Okay. Well, great. These are questions that I had, and I'm sure the audience had a wonderful time listening to a very unique presentation that you had of a patient actually presenting in a gravid state with a pneumothorax as the first, as you mentioned, the age is 35, which fits the patient criteria that you had, and 70% probability or likelihood of having a pneumothorax as the presenting sign. So wonderful case discussion there. So thank you, Amar, on time, and I appreciate you prepping for this and preparing for this. So thank you.
Thank you so much.
Thank you everyone for joining, and have a wonderful evening.